Okay, so good morning, Josh. Thank you for reading with me today. Could you just introduce who you are and your role in the medical team?
Sure. Hey, everybody. My name is Josh Geltman. I am an attending physician in the ICU at one of Northwell's community hospitals, Northern Westchester Hospital. By way of background, did all of my training at North Shore and LIJ on Long Island with Northwell. I did a combined program of internal medicine, emergency medicine, then ultimately critical care fellowship, all at North Shore and LIJ. I know Katie from our work in the PZD together, and she's been my bestie for many years now. So I'm really excited to be here with you guys today and to chat a little bit.
Awesome. Thank you, Josh. So I want to jump right into it, right? You mentioned your triple board lifestyle. You mentioned the EMIM program. What is that, and how did you even find out? Because it's not a very common residency program.
Totally. So, for me as a med student, I loved everything. And which a lot of people, that's like the common plight of a lot of people in med school as they go through all these rotations, like, yeah, that seems good. I can do that. And then the next one is, I can do that too. And they're like, oh God, I can do this one three. Oh, okay. What do I do? Um, so I knew first and foremost, I liked the care of a hospitalized patient, of like a sick patient, right? I loved med peds, but I found that med peds was a lot more outpatient focused, and EMIM was kind of the inpatient version of that in my mind. And so I only knew about it because as I was really an late third year, early fourth year looking to do away rotations, I was going to apply primarily to emergency medicine for the reason of it sort of like takes all comers and ages, like from the adult side, and you get to work with all these different services in the hospital. And for me, I have sort of a businessy background. I got an MBA before I went to med school and kind of came into med school thinking that I wanted to at some point do healthcare leadership in some way. And so for me, I thought EMIM was this beautiful way to meld all of these different things that I was hoping to achieve, getting to work with all these different services, becoming the sort of like full gamut physician that could take care of anything, especially sick patients, which I really liked. And then beyond that, also see how the healthcare system functions from outpatient medicine as a medicine resident doing clinic all the way through the ER, the inpatient side, and then the ICU if necessary. And then maybe do something later on as a chair or as a CMO or something like that, having that experience of the full stack of the patient experience. So that was like kind of the broad strokes of what drew me to that. And I only discovered EMIM as a way to do that when I was looking for a ways for EM. So during when I was applying, we were still doing audition rotations at a lot of these EM sites. And so that was pre-COVID. And so I did an away rotation at LIJ. And that's when I knew going in that I discovered that they had this EMIM program. And I was like, wow, this seems like this could be this great overlap of things for me. And then I got there and really fell in love with it and the residents and the idea and sort of seeing how it actually worked in real life. And then I applied and got an interview and really loved it some more. And that was my top rank. And so I got it. So uh, it's a, it's a pretty cool kind of niche thing that not a lot of people know about, which I'm glad we're talking about it today.
So you mentioned that now you're an intensivist.
Yeah.
And so what kind of path, how did you get to critical care medicine? And speak a little bit about how you get there from EMIM.
So we were really fortunate that at North Shore and LIJ, the relationship between the EMIMs and the ICU is really close. And so we ended up getting more ICU experience as part of our curriculum throughout the early years of our residency. And in the years before I started, a more formal relationship started to form between the ICU and the EMIM folks, where you could apply for and subsequently do an additional year of training and get an ICU fellowship out of it. So not pulmonary critical care, but just critical care. That program has evolved even more now, where in addition to that pathway, that you can do it via internal medicine or emergency medicine categoricals, also apply to critical care fellowship, which is 2 years instead of one at North Shore and LIJ, which is just starting up this coming year, which is pretty special. So
Yeah.
um, as I mentioned, I really enjoy the care of these complex hospitalized patients, and critical care is kind of the next level in that, right? And so I fell in love. My first rotation wasn't even until January of my intern year in the ICU, but I got there and I'm like, this is my happy place, which is kind of weird for people to think like, wow, these like dying
Especially in the dead
patients
of
are
winter.
like your happy place. What's wrong with you? But like, I'm a nerd in general, and there's a lot of nerdy stuff to do there, right? You like have
A
to
lot
care
of
about physics and
formulas.
stuff
Yes.
and like math, and like that's not the primary reason why I do it, but like I just found it so fascinating. And just like anesthesiologists love how physiology kind of comes alive while they're taking care of a patient under anesthesia, it's the same idea, even in the ICU, and even though not everyone's on a vent, ideally, and so you're able to make these like huge impacts on a patient's outcome by making some decisions and using technology. For me, I'm a big point of care ultrasound guy. That's been kind of my career niche that I've started to carve out for myself, and I fell in love with that in the ICU. And so you get to use all these cool toys, push lots of buttons. Who doesn't love that? And be nerdy. And so for me, I found that that was a really yeah, fun place, and the people were fun and like-minded to me, and I really just felt at home there.
Yeah. What do you think critical care medicine teaches that you wish every doctor knew?
The biggest thing in the hospital that you see are people lock up when they get a sick patient, feeling comfortable in a how to run a good RRT, how rapid response, how to run a good code, how to control the emotional temperature of a room,
Mhm.
and how to approach taking care of a decompensating patient to ensure the best outcome. And so I love teaching that kind of stuff. I love working across silos, right? The medicine silo, the
Mhm.
critical care silo, the ER silo. Like we're all a big family. We're all taking care of these patients in the hospital. And I really love being that glue to try to bring everyone together with like a shared understanding of how to take care of these sick patients. That's like fun for me. But I think that's what a lot of us really like to do, is to come up with a plan to work together to take care of these sick patients.
So let's say that you have a third year or fourth year medical student on their clerkship, and they're really just starting to go to the ICU, and maybe it's a small fraction of their medicine clerkship. And that's exactly what they're afraid of. They're afraid of the sick patient. They have
Yeah.
spent most of their time, especially in their preclinical years, just in an outpatient clinic. And
Yeah.
so seeing the sick version of that is intimidating. So, what would you say to that student?
So there are a lot of like really great resources available to help that exact person.
Mm-hmm.
So New England Journal of Medicine has a website for rotators, for residents, actually, Resident 360. And the cool part is normally you have to pay money to like have access to all of the different parts of Resident 360, but the critical care tab is free. So that's like a big win for everybody. So regardless of who you are, you can log in to NEGIM Resident 360, go to the critical care tab, and all of the tips and tricks for your rotation. This is geared towards interns, but it obviously is quite applicable to anyone that's interested and going to be rotating through on the third, fourth year. An additional resource, a great resource that I still utilize because I think it's a great resource, is this website called EMCRIT, EMCRIT. So it's started by emergency medicine and ICU people. This guy, Josh Farkas, is one of the guys that curates the critical care piece of it. They have podcasts that you can listen to on the way into work, which I listen to on the way into work also. He is super, super, super smart. And he does like small podcasts on like, how do you convert a VBG to an ABG in your mind to know if it's good, or like
Mm-hmm.
where, or like how to manage DKA, soup to nuts, how to manage all these very like classic things that you see in the
Yeah.
ICU, broken down with pictures and really great infographics that make it very accessible. POCUS101.com,
Mm.
phenomenal resource for people to have no exposure to POCUS, to go there, and it walks you through how to do an exam, what your image should
Mm.
look like with like GIFs or GIFs, depending on your flavor, uh, and like step by step what ribs you should be going between, or like very
Yeah.
user-friendly and approachable way to think about ultrasound. I refer every learner that I'm encounter that I'm teaching ultrasound to, I refer them to that website. So asking lots of clarifying questions in advance is great. Coming a day early if you get out early, and like being and like ask one of the nurses to show you where all the stuff is, right? Med students love to feel helpful, right? You can only feel helpful if you kind of know how you can be helpful, and knowing where stuff is like a perennial win for med students, right? So knowing how you can help, being when you show up on the first day, asking who the nurse is taking care of the patient that you're picking up, engaging with them before formal rounds. So when you're going around and seeing the patient, part of your pre-rounds is always talking to the bedside nurse, either the night nurse that is coming off or the day nurse that got reported and is coming on for the day, because they know a lot of the nitty-gritty details that are going to make you look like a star on rounds because you know the patient, right? So your job as a third and a fourth year med student is to know your patient better than anybody else, right? To know their family, to be that point person, to like know their backstory. And so allowing yourself the time that you need to feel like you've gotten the gist of who the patient is before we meet them, right? Because we meet them in this very vulnerable state where they're sometimes not even talking to us or on a ventilator. And so like we have to play detective. We have to look to see if they got their nails done recently. We have to see how their hair looks, like we look at their tattoos, right? And like piece it together if the family member's not in the room. And obviously talk to the family members when we can. And so as much of that as you can do, the best you can know your patient in that realm is even more helpful than it is in every other setting where you're doing the same thing, right? Because we end up having to play detective a lot more because our patients can't always talk to us.
So let's say that that student is prepared. They've come in, they've listened to the same podcast as you coming in, and now they're ready to take the next step. They want to get an honors in critical care because they've decided that's what they want to pursue, or they just realize that it's an asset to have an honors dealing with the sickest patient.
Totally.
So, do you have an example, maybe on rounds, or maybe even with the afternoon, or with the patient that they're carrying? What does a high pass student look like, and what does an honors student look like? What's an example of something that would move the
Push them over
needle?
the edge. Yeah.
Yeah.
So one thing that as I try to grow and develop all the med students that rotate through with us, as the weeks go on, I try to push them to start presenting without notes. So, or at least minimizing the amount of notes that they use. Everyone has experienced the Dear Diary presentation, as I like to describe, like any floor presentation or a clinic presentation or ICU presentation, where it's monotone, it delivers all the necessary information. They may be great at collecting and collating history and physical, but the delivery is such that everyone immediately tunes out, right? And so the way that you can really impress, I think, is your public speaking skills, I think, make a big difference, right? And it's challenging because some people, various people feel more or less comfortable presenting in front of other people. You know the information, right? So you're the person that knows the backstory. If you have to refer to what the specific number for the ins and outs, total was, or the specific white blood cell count, fine, no problem. But rattling off in a very nice narrative what happened overnight. This is our 78-year-old man who's in the ICU for acute decompensated heart failure. Beautiful one-liner, crisp, chef's kiss. Everyone knows why they're there, right? So now you've primed everyone to listen. I give this advice to everybody. Like when you're telling the story, this is our patient, 78-year-old man who's here for septic shock, right? They have lots of other stuff going on, right? But that's the primary reason they're in the ICU today. Then everyone's ready to listen for everything else you're about to say in a totally different way. So you do that and you say, overnight, we were able to wean him off of pressors. Mental status improved, his urine output picked up, his white blood cells count started to come down, as like a big overarching summary. Again, you just told a very compelling story. We can get into the details, and we will, but everyone now has a much clearer trajectory of, okay, this is a happy story, or this is a sad story, or like, where are we going with this, right? And then you can launch into the presentations that we do in the ICU are more systems based, right? So we do head to toe instead of problem based, which is where
Hmm.
a lot of people will, the usual SOAP kind of thing is more problem based. So um, you'll find that in any ICU that you go to, there's sort of a normal stepwise approach to your presentation. You can get that down fluently. You can tell a tale and you understand the trends and what trends are important, right? So a white blood cell trend is important, a creatinine trend is important, right? A platelets trend is important, a hemoglobin trend is important. The absolute numbers are not as relevant as are we headed in the right direction or things are not going well,
Okay.
right? And so having that clear grasp of the next level, other than being a great reporter, you're also synthesizing
Hmm.
and then taking it to the next level.
Yeah, turning into that interpreter and showing that you've done that is really like that foundational step because that's the only next way you can get into the next step of like managing what you're doing with that information you've interpreted.
Exactly.
Yeah.
Honors students also know the social story and the background and like the context of what's going on with that patient and can
Hmm.
speak to that. They also are engaged after rounds and
Hmm.
frequently assisting the nurses or the ACPs with whatever needs to be done in that room. You know, if they need to an extra hand going to transport to CAT scan, you're
Hmm.
always
Hmm.
there. The engagement piece of it
Hmm.
is definitely what's going to take you over the top.
Besides obviously the like leaving early or showing up late, those like obvious things that don't reflect well on a student, is there anything ICU specific that a student should avoid doing?
Never be dismissive.
Mm-hmm.
That is a pitfall that I have seen time and time again of I'm a med student, I'm not a nurse, that's not my job, right? Like
Mm-hmm.
I help move patients, turn patients, clean up patients, help people to CAT scan. That's an everyone job, right?
Hmm.
And the way that you have to approach it is like, what would you want for your family member? And if you can always answer that you're doing the right thing for your family member, then you're good. But if you conceive of yourself as that's not your job, then that'll be a big pitfall, I think, for anybody,
Hmm.
regardless at any level. And then reporting things that you're not sure of and saying you're sure of them, right? So
Hmm.
it is okay that you don't know every answer that I ask you on rounds.
Hmm.
Just practice in the mirror every morning. I'm not sure what the answer is to that one. I'll look it up
Hmm.
and get it back to you and get back to you. That is perfectly acceptable. We would love for you to have every answer, but we also understand I would much rather hear, I'm not sure about that, or I don't
Hmm.
know, than coming up with a plausible answer. Like my wife broke me of that habit a long time ago. And it's a great lesson for everybody for
Hmm.
all for at any point in your life, at work and at home. So, but especially you always want to, you're trying to look good, right? You're trying to
Hmm.
look great and you want to have all the answers. It's okay to not have the answers. The worst thing is you say something that's like diametrically opposed to reality and then everyone knows it and you're like, okay, now you're a liar. Like you don't want to be,
Yeah, yeah.
that's not good, right?
Hmm.
That will blow up in your face. Um, so yeah, just knowing what your limits are in
Hmm.
real time and acknowledging them is a very human thing to do and will go a long way.
So, what's the best piece of advice that you received during your own training?
It's a great question. Even just finding a mentor in med
Hmm.
school is like the biggest win that you can do. Someone, a clinician that will truly get to know you and like wants to be invested in, not just as someone who's going to write a letter, but someone who's going to get to know you.
Hmm.
And so that I think is the biggest thing that third year med students can do.
Awesome. Okay, good. Thank you. Josh, I really appreciate your time. This was so helpful.
This was a lot of fun. It was great to have a chance to work on this thing with you. Hopefully it'll help many, many people.
I hope so.